Hello and welcome to Health Live at Seniors Today. We have here with us not one but two doctors, as I mentioned last week. We have here with us Dr. Rajam Iyer. Dr. Iyer is a leading pulmonologist and a palliative care physician with the Bhatia and Hinduja Hospitals. She has been a practicing pulmonologist for 25 years, and her aim is to provide good quality healthcare in a compassionate manner. He believes that educating patients and their families is the key to improving healthcare in India. The topic that we have here is dealing with chronic illness, patient rights and comfort, planning the road ahead. We also have here with us Dr. Sujeet Rajan. We've had Dr. Rajan here with us twice before. He is, as you know, a leading respiratory physician with the Bombay and Bhatia Hospitals in Mumbai. He graduated from the Grant Medical College in Mumbai in 1989 and post-graduated in respiratory medicine from the GS Medical and KEM hospitals also in Mumbai. So, welcome to Health Live at Seniors Today, Dr. Iyer and Dr. Rajan.
Thank you very much, Pradyuman. Great to be here.
Great.
Always good to be here
with us. I'm going to start off with you, Dr. Rajam Iyer, about what is palliative care, and could you start off with a few opening remarks on what it entails?
Sure. So, unlike what most people believe, and I think most people get put off by the word palliative, the definition, according to WHO, of palliative, which is also revised in 2017, is mainly addressing the health-related suffering that patients and their families undergo when they have when the patient is diagnosed with a chronic illness. Chronic illness need not necessarily be something which is incurable. Even the curable disease which lasts for say 3-4 years, like cancer, is also something in the purview of palliative care. So palliative care basically addresses health related suffering for the patients and the family, and it's not just the physical issues, it's mental, psychological, financial, spiritual that the patient and their caregivers undergo during this difficult journey. The idea is to address them as early as possible, acknowledge them, and try and support the patient and family through their difficult journeys. So it's something that probably doctors did many years ago, till modern medicine came and there was specialization and super specialization, and the focus completely shifted on cure, and somewhere comfort, care, and the holistic health was forgotten. So that's what palliative care is aiming to bring back, which is compassion into medicine.
You know, when we announce this session, and we normally get a lot of questions coming in from our readers who want to pose these questions and possibly don't want to ask it over here live, is questions which are beyond medical. So there are ethical, moral issues that have been raised. So we're going to ask all these questions to you, and those of you who have questions can put them in the attendee mode. Can put this in the Q&A mode over here, and please address it over here, and we will ask Dr. Rajan the various questions that are there.
Look forward to answering them.
But you know, I must tell you that over the last, we had Dr. Sujeet Rajan here a few months back, and he was talking about palliative care. And I must confess to you that while we are all about senior citizens, etc., but we thought of using or discussing palliative care much later after we've done with the various core illnesses, etc. But you know, the fact is that he spoke to us and he said it must be done as soon as possible. So, Dr. Rajan, I must ask you this question: how come, you know, you are evangelizing this? Because at the end of the day, you know, the palliative care specialist actually takes away people from the doctors, right? And here you are an evangelist, and you've been talking about it, and you do underscore the need for quality care in this area.
Right. Pradyuman, the key issue here is that, as Rajam rightly said, I think we have lost our purpose, many of us, in what we set out to be as doctors, getting embroiled in the hospitals we are attached to and the priorities of the hospital that we need to sort of address as well, and I got into respiratory medicine, setting out to, my objective was just to be a good respiratory physician someday. And I think I was doing that job reasonably well till Rajam came along. That was about 10 years back. And she was in Hong Kong that time. And when she had taken a break from respiratory medicine, Pradyuman, and wanted to get back into the segment. And we know there's a shortage of respiratory physicians across India. And the commonest reason a patient goes to a doctor is for a respiratory symptom, actually. And this has been very elegantly shown in a study that patients visit their doctors. If you look at all symptoms, a respiratory symptom is the commonest. Now, having said that, obviously everyone with a respiratory symptom doesn't come to a respiratory physician. They go to their family physician, right? But the burden is huge. And we were for some time seeing patients together, and our patients, or at least my clinic, had a lot of patients of COPD, lung fibrosis, bronchiectasis, pulmonary hypertension. And for any of the audience who don't know these diseases, these are basically fairly chronic lung diseases, which patients have to live with. Most of them, there is no permanent cure, but they can live very good quality of lives, even with COPD, lung fibrosis, and pulmonary hypertension. Having said that, they're elderly patients. And so I got to realize that a lot of these patients needed much more time to get into my room and much more time to just step out of my room, if you get what I mean. So these are frail people who needed, and so they would take up a lot of time. And I realized that many of my colleagues probably weren't that happy managing such patients because they took so much time to address. Sometimes they were hard of hearing. Elderly patients start losing hearing after some time, and so it takes longer to comprehend what you're saying. But what I realized, and I think even Rajam realized at that time, is that if you do give them that time, they value that time tremendously. And we realized that, in fact, we never even thought of palliative care at that time. We just thought of advanced lung disease initially and said, when patients have a chronic lung disease and they need more time with their doctor, whether it's just to be listened to or whether it's to address symptoms, which we are so focused. Chest physicians are so focused on making a great diagnosis, doing a procedure, writing out a prescription, that they've sometimes missed the forest for the trees. And the patient has one complaint he's come for, which you haven't even heard. So then we said that let's spend more time with these patients. And why doesn't Rajam see all my patients who need that extra time? And then I think nothing stopped after that. It just started exploding as a branch, basically called palliative supportive care. It's been there for a while, but a very underestimated branch of medicine, and something that you'd say should be the fundamental part, Pradyuman, of medicine, in that every doctor should be doing this, right? But it doesn't happen because of technology today. I per se see reasons as there's so much technology. Hospitals have invested a lot of money in infrastructure, and rightly so at times. And doctors have to have this perennial be positive attitude all the time, which again, to me, doesn't make sense in many situations. And also wealth. And where I practice in South Mumbai, there is a significant amount of wealth. All of these things make patients feel that when you talk about quality of life, they somehow just want a cure, a new medicine, a new procedure, and which actually makes their quality of life worse. And there's no discussion on these things often. And that's what has been the most amazing part of the experience in the last few years, to get that discussion going. I don't know what you feel about it, Rajam.
I think there are very few sensitive pulmonologists like Sujeet who thought there was a need for this. And coupled with the fact of my own personal experience of the manner in which I lost my father was, instrumental in where I am today. And I think in the manner in which we looked after him towards the end of his life, I think it was very crucial for me to start thinking that if I struggled, to make that decision of giving him comfort care and of basically not admitting him to hospital and keeping him at home with dignity and respect. And that's what got me thinking, saying that the other people, common men, people with no family medical support, will rush to the hospital and probably will end up doing all that as advised by a trained healthcare professional who's focused on cure, and more cure. And that leads to a lot of health related suffering, not just to the patient. Patient probably has not been asked, or there's no choice, or patient's not even in a position to give his or her consent. But at the same time, the guilt that family feels at that time of how can I not do anything. So these kind of thought processes is what made me realize that I really need to go back to training, and which is where I got my palliative care training. And along with Sujeet's help, it's been a great journey to support those people who we don't have cure for, who suffer a lot with high symptom burdens, and even if not respiratory wise, even just the frail elderly citizens or those living alone, there's a lot that we can offer, because it's not just the physical symptoms that bother these patients or people. It is basically a combination of emotional, psychological, social, spiritual, and even financial, considering that a lot of our medical expenses is out of pocket in this country. So I think it's that, therefore it's been an extremely satisfying journey. I have learned a lot. And many people wonder how I can not feel morbid and depressed thinking and talking about death and dying and people who are so sick. But I think my perspective to life has changed. My perspective to life and living has changed by looking at these people and taking care of these actively dying patients and being there through their difficult journey. I know how to cherish every moment and live every day. So I think it makes a big difference, and it's been a very positive influence in my life.
Yeah, I hear you, Rajam, on that. But I was just thinking there are a lot of people listening who are wondering whether doctors are trained on this aspect of medicine. We know it's a branch that's been there for a while, sort of taken the backseat because of technology. And I'm never against technology and innovation. We'd always like to know something new. In fact, we never give up on something that could actually improve a patient's quality of life and extend his life, which for a reason that he would enjoy. But having said that, are doctors in India, what is your feeling on doctors in India in general being trained in palliative care and supportive care medicine? Because this should be part of training of a general practitioner to a super specialist, in my opinion. What is the current situation if the average audience goes and meets their physician? Are their doctors trained, or is there training?
So Sujit, you and me probably got trained at the same time, and both of us know that the focus of our training has been cure and save. Somewhere we talk about health care today, and both health and care are not focused on. So if one of our participants actually go to one of their doctors, the focus is on, like you said, getting to the diagnosis and writing out a prescription. Whether the patient is coping with that diagnosis, whether the family is able to protect and support the patient with that diagnosis, is the patient's, say, the house, is it comfortable for that patient to live? For example, a respiratory patient has a gas cylinder and an oxygen cylinder next to each other. So there is so much about care that we can actually convey to our patients. The second thing is about health. Now, the WHO definition of health itself is not just the mere absence of a disease. And somehow our doctors are trained, all of us, including me, have been trained to focus on physical symptoms. We haven't been trained to focus on emotional, psychological, spiritual, and financial aspects that go along with physical health or physical ill health. The other thing is, the biggest drawback is that we are not trained to talk empathetically, compassionately, We don't know. In fact, we feel by asking these difficult questions about, are you coping okay? Is there anything else I can do for you? We feel we're going to open the Pandora's box and, oh God, I don't have the time and there are 50 patients waiting outside. So communicating well doesn't mean it takes much more time. It's just that you need to be an effective communicator, and you don't have to be born as a great communicator. I think it's a skill that can be practiced. The point is that you need to know that you really, you have to perceive it as a need. Doctors don't think that they need to perceive it as a need. And that's where I think they don't put in a little bit of emphasis on wanting to learn to talk. I think if you talk well, if you get to the level of the patient, if you realize that the patient's issues are not just physical, and if you have that little bit of intuition and antenna when you're talking to patients, I think it comes automatically. Because I know I have changed in the past 4 years. I probably used to stick to physical symptoms and, and dishing out a prescription. But just one question of, are you coping okay? Is there anything else you would like to ask about? It kind of builds a rapport with the patient, and the patient really knows that it's not just that this doctor is treating, but the doctor also cares. Again, just one thing I would like to add here, Sujeet, that I know I don't have solutions for all the patient's issues. I can't help him change house. I can't help him become richer. But at least I address it. I acknowledge that, yes, I can see that this is causing you distress, that yes, I can understand, but let's together work towards how we can solve it. Okay, if you think I can talk to your son, I can talk to your daughter, I can talk to your landlord or something like that, at least that effort from the doctor makes a huge difference, that this person is there for me, not just to dish out prescriptions, but also to hear out what I'm actually trying to say. I think that is very important, to have that trust, I think, which is probably what family physicians did many years ago, or even before modern medicine came. Doctors sat next to the patient, comforted them, listened to them. There wasn't any NIV, ventilator, ECMO, the higher antibiotics, but at least doctors had a compassionate approach towards what their patient is going through.
Sure. Yeah, I agree. I agree that change is slowly happening. It's slowly happening, and I must actually thank Bhatia Hospital, where I work, for being agreeable to even having you on board that time, because I know that hospitals have usually asked, how can revenue be enhanced? Because our health sector, as you know, Rajam, is a lot about private medical care. 70 to 80% of healthcare in India is private.
Correct.
And so a hospital has to be financially viable, and therefore they see patients going home sooner as obviously dropping revenue to the hospital, which is, however, if those patients go sooner and patients who need to actually come in, then you have a good turnover and you improve the goodwill of the hospital, I think. And,
absolutely,
and that leaves more satisfied patients, I guess, leaving the hospital. And I think sometimes, Rajam, I get this feeling that people above the age of 65 especially have at least one or two often chronic illnesses.
yeah.
Do they have rights? I mean, do these patients have rights that they should know about, since that's our audience we're addressing today?
Absolutely. So I think literature does say that even if, so most senior citizens, once they hit the age of 65, have at least one or two chronic illnesses, or maybe more. And they might not be life threatening, but they may be definitely life limiting. And that's the reason why it's important. Like when we say about hospitals wanting frequent turnovers or more bed occupancy, I think we really need to focus on the fact that patients, according to even medical ethics, have autonomy, and we really need to ask patients what they want. What is their choice? For the patients to make these decisions, they need to be well informed. So I think the rights of the patient starts with the fact that it's a doctor's responsibility to explain the illness to the patient, or the disease trajectory, the natural progress of the illness, so that they can make informed choices. And very often we see that doctors don't ask patients, okay, so this is it. I can give you 1, 2, 3. These are the side effects. What is your opinion? Because what may be food to you may be poison to the patient. So we really need to focus on the fact that patients do have rights. they must have choices. It is their body, their money, therefore it has to be their decision. What we can do as physicians is explain to them and then let them make their informed choices. Their information shouldn't be coming from Google and other websites. Their information should come from their doctors, and then that can help. So autonomy is a first pillar of medical ethics, and it's extremely important. And it not just goes with respect to treatment, it also extends to aggressive treatment in cases of patients who are seriously or acutely ill and need to be hospitalized or need to be put in the intensive care. So autonomy has to be first. Also, alternatively, Sujeet, tomorrow I'm going to be in that position. I don't want a strange ICU doctor to make a decision for me when he doesn't even know who Rajam is. I mean, I have definitely will have an illness, but I also come with certain beliefs, values, fears, desires, and these things need to be addressed when I'm well, so that people around me know exactly what to do when I am seriously unwell. All our patients have the right, A, to express their wish of how they want to be treated, and most importantly, refuse treatment that they feel is not going to help them. So, as you know, the second and the third part of medical ethics is something that you do to benefit the patient. So, beneficence is important. We should offer that treatment which does not cause harm. So, do no harm is one of the Hippocratic oaths, right? So,
Right.
we should do everything in the best interest of our patient, not cause him harm. And one other point I would like to highlight, since we are in a pandemic, I think the COVID-19 pandemic has brought health, death, dying into very sharp focus. Also, because we have an overwhelming number of people all sick at the same time. I don't think the best of the healthcare systems in the world, like America and UK, even coped with it. So, in such a situation, the doctors also go through moral distress of whom to put on the ventilator, whom not to. What is the criteria to decide that? That comes only with discussions done much before. That comes only with communication and documentation. So I urge all the senior citizens who have logged in today, who are already, I know, thinking about this, but please talk about it. Because somewhere you will be doing yourself a big service and helping your family avoid guilt, and very much the healthcare system, because the healthcare system is very much overwhelmed now. Plus, I think it's very important that you have a choice in this matter, and there is a choice. Supreme Court has also allowed you to have this choice. You have the right to refuse treatment and also to express what you would like to be done in a case of an emergency. But for all this, we doctors have to foresee and foretell and have to explain to them about their illness. Otherwise, it's very difficult for them to make informed choices.
Yeah, I think when you say choice, I remember one statement from the Palliative Care consensus statement, which said the only thing worse than chemotherapy is not to have the choice to have chemotherapy. You know, so I think that to me was so important, in that chemotherapy can be useful, but it can have its issues. So just a discussion, just a discussion can help a patient make that informed decision, like you said.
Because sometimes, Sujit, the treatment can be worse than the illness.
Yes.
So if
yes.
you have a patient, like you said, about stage 4 chemotherapy, the basic human instinct is to continue life.
Correct.
We are a death denying society.
Yeah.
And then if the doctor, who is so educated with experience, says, this one drug, just try this one drug, it's very hard for the patient to say no.
Sure.
And unless the doctor explains that, these are the pros, these are the cons, only then you can make a decision. And those patients, we have seen ourselves, who take that last bit of chemo, instead of spending those last 2 weeks, even 2 hours comfortably in the surroundings of their home with loved ones, talking or just being with such familiar touches, familiar voices, he's alone in a hospital with strange people, with people prodding everywhere, with tubes in every orifice. This is not dignity, and unfortunately illness strips you of dignity. The least we can do for a patient is treat them like human beings.
Sure. But moving away from death and advanced disease to life in general for an elderly patient,
yes,
are there any areas that we tend as physicians to neglect that patients have? Because I know I've had sometimes a half an hour session with a patient with a lung problem, and then he's got up from the chair and said, actually, I came here with giddiness. And you haven't addressed that at all, So I felt very embarrassed at the end of that half an hour consult. So are there areas that we could be completely missing in geriatric care, elderly care?
So I think with senior citizens, a lot changes once they hit the age of 60, 65. And it's also, even if they're not, even if all their parameters are fine and they do not have any ill health, they definitely are slower in reflexes. They definitely are, reached a situation where they double check themselves or have an issue with confidence. They recheck things, etc. So I mean, there are also, I think the world has changed today more so with COVID, but also because families have become smaller. There are more nuclear families. So elderly are staying more and more alone. Some of them have absolutely no kith and kin in the city that they are living in. Children have moved out of the cities or maybe even out of the countries. And during the pandemic, it's been complete no communication. Sometimes after having lost their spouse, there are people who are all alone. And sometimes there are spouses, for example, one 75-year-old looking after an 85-year-old. So all these are very challenging for elderly. And I think when we see these elderly patients, it's important that they accompany with somebody younger so that they understand better. Anyway, I think two people is best to come to a doctor with, because what one doesn't understand, probably the other does understand. Something that has fallen away from the patient's receptive level can reach the one who's accompanied. Second thing is always to make them recapitulate what they understood. So you might have said, say, point 1 to point 10. They might have heard 1 to 8. They must have understood 1 to 5, and they might only recollect 1 to 2. So you realize that this gentleman probably needs another session, which you don't have the time to. So that comes in the role of a family GP, or that comes in the role of a palliative nurse who can reiterate, who's sitting outside or whatever, saying that this is what you need to do. And the other issue is we often forget that elderly have a lot of mental health issues. And we really need to ask them, about, because I've heard this statistics from you that the cause of weight loss in elderly is 70% is depression. And we really need to get and rope in specialists who are trained in geriatric psychiatrists. We should be open to the fact of referring our patients to them so that they get the adequate help, especially if they're living alone. We have all experienced what it is to live in your own room or in your own house for unlimited periods of time. For some geriatricians or some senior citizens, that is life. And it can be very daunting on them about how they live to the next day. So that kind of support and that kind of reaching out and asking the right questions about whether they're sleeping okay, whether they're eating okay, and what was the meal they cooked. Sometimes they don't cook for 2-3 days in a row, and obviously they're eating something which has come out of the fridge, which could also cause a lot of issues with their health. So I think these are small things, and having lived with somebody growing older for the past decade, you realize there are small issues like picking up the phone, they can't see the numbers, or answering the doorbell, or now that you have the grandchildren and everybody on the tech with Zoom, etc., they are not tech savvy. So I think even this generation of senior citizens need to get tech savvy, because that's where the world is headed to. And it's important for even doctors to suggest that the more they are in touch with their peers and their family, it also helps them, because I think there is research to suggest that too, that if you have a good social life, you live not just longer but also happier. So I think it's important for us as doctors to pick up these things and point it out to the family physicians. And that's another very important thing, that every senior citizen must have an identified GP. In a COVID world, when you can't just rush to any hospital, you need some medical help to come to your doorstep. So you need that kind of a family physician support. And that's something, again, which you and me have talked about very often, is a dying breed of physicians. But we really need to encourage senior citizens to identify one.
Sure. I think, and as you rightly said, before I hand over to Pradyuman, I think without a family doctor, patients can't just keep ringing up specialists. They're difficult to reach sometimes. And the family doctor being trained in symptom management, as you're talking about. It's really all about symptom management, reassurance. Is that happening now in India, you think? Or is there a
So
degree for them or a course?
So there are centers across the country now who are offering on a digital platform. In fact, we are just doing one for Bombay GPs,
Right.
spread across about 14 weeks, where we are training them in simple principles and concepts of palliative care so that they are more confident in going to a home and
So,
looking after a patient and not looking at the patient and saying refer to hospital. So, it's important to handhold the GPs also to
sure.
see to it that they have the wherewithal to be confident, to look after and keep the patient comfortable at home. Because once the patient is comfortable, the family is comfortable. Problems arise when you are not able to control the patient's symptoms, and then obviously family panics, and then they can only think of hospitals. So
So,
that's where then once the patient enters the hospital, it's like a conveyor belt. Then it's hospital, ward, ICU, ventilator, and nobody sits back to think what is necessary and what the patient needs. So I
so
think therefore it starts from the family physician, and it's very, very important to train them and to have one.
sure. I think that hospital story is another story which I will come to maybe later if Pradyuman gives me time. But I know the nightmares we go through in hospital with some patients and some well-informed patients where the journey is so smooth. I mean, there's a stark contrast between an informed or reasonably informed patient arriving at the hospital very sick compared to a non-informed patient. Pradyuman, I mean, I'm sure there are questions. Would you like to take some of them?
There are so many questions, and as I mentioned, most of the questions are not on medical issues, but on other.
Sure.
We have a comment here which I must say, and I kind of echo this. Is that one was an amazing discussion that was there, which both of you had. It was, of course, a bit of a worry also that some of the issues that you discussed, that they exist, and the fact that they're not being tackled well enough, because if both of you kind of spot this problem, this malaise that exists in our healthcare systems, and obviously for the lay citizen, uh, the concern is so much more. But we have a remark from uh, Vijay Rajan, who says this: thank you for this useful discussion. I feel when we speak of care, especially at home, for senior citizens who require an enormous amount of care and or are bedridden, there's a lot of burden also on the caretakers. I feel there's not enough support system for that in India. It takes an enormous emotional, physical, and financial toll on the caregiver. We don't have good, dependable database on nursing care. And it's good that this remark is made, because the first question that we have is on caregivers. And my question to you, Rajam, is that there's no clear training available for caregivers. How does a caregiver get to know about conditions, about how to take care of patients, etc.? Is there a method in which a caregiver can get training, not just in medical issues, but in emotional issues? Because sometimes the journey to get ready, to get well, could take years or perhaps never end.
So true. I think it's one of the topics which is very close to my heart, having been a caregiver myself. And I think in life, all of us are caregivers. Either we are now, or will be, or we will receive care at some point. And they are the silent soldiers. They are the silent warriors. They are unacknowledged. And somehow in this country, the culture is, of course, you have to look after your husband. Of course, you have to look after your wife. How can a son not look after the father? So they are also thankless, because I think nobody acknowledges their effort, their complete change in life. So thank you to Vijay who made this comment. Yes, it is an extremely difficult situation, and they not only go through physical like the patient, they also go through emotional, psychological, and in some cases financial. I've had friends who've locked up their businesses and jobs in the US and come to know they don't even know how long to look after their father. So it is a life changing event for the caregiver also. So now, I mean, to be honest with you, palliative care addresses the caregiver compassion fatigue and compassion burnout. and the family GP and the palliative care physician or the volunteer. So for example, since I have looked after a stroke patient, we encourage people who have done it for their loved ones to teach the ones who are currently doing. So palliative care, the beauty of it is because it's a teamwork. It's not just doctors. There are nurses, counselors, physiotherapists, psychologists, psychiatrists, as well as volunteers who've been through it, who've looked after cancer patients, who've looked after patients who are happy to form a support group. So one of my friends, Bhavna Isar, has made a group, has made this NGO for caregivers and called it caregiversathi.co.in. And she does a lot of work to see to it that caregivers have a place or a forum to complain, vent their frustration, cry. There are support groups for disease-specific illnesses. So do check out her website. And I will also request Pradyuman actually in this, in the series of events to probably even have Bhavna on your show. She does some amazing work as to, recently for COVID, for the way grief and bereavement has changed during COVID times. We've had a support group for bereavement, so that people can come talk about the loved ones they lost, how they felt, how they're trying to cope. And like I said before, it's not possible to get solutions for all, but at least we are there to hear. Being there, I think, is the most important part. And the fact that they can reach out to someone, that should be important. And caregivers need a big pat on their backs. And thank you for all the wonderful work you do to look after the patients. I know you do out of love, but it does obviously take a toll on yourself. So look after yourself, keep yourself 100% fit so that you can look after them better.
One of the points that Vijay Rajan has raised is the financial toll on the caregiver. And fact of the matter is that while you have medical insurance available, and a large number of people have taken medical insurance, but still the care that is required, and especially when care is being given at home, is a financial burden. So are there opportunities available for people to dip into some funds that may be there, loans and those?
What you're talking of, Pradyuman, if I understand, is the unskilled help that you need, the hard, like ayabais, ward boys. Yes, they are very expensive. And I think, unfortunately, it's not even covered by all the medical insurance and help that you get. But, compare that to curative treatment. If you do the economics, it is the amount of suffering that both you and your patient undergoes is way less. So the investment, I know, it's not cheap. They cost something like 600 rupees per day per shift, etc. So it is expensive. I'm not denying that. But if you compare that with aggressive curative treatment that patients take their loved ones for, even when the percentage of or prognosis is poor, that is much more, way less. Also, another statistics to tell you is that we have in our country 55 million people going below poverty line, trying to save their loved one in the last 2 weeks of life. So that's the amount of health economic burden that we are causing by trying to save people who have poor outcomes. So I think a lot can be done. I'm not denying the fact that caregiving and taking hired help, unskilled help is expensive. But if you compare it with hospitalization, compare it with aggressive treatment, compare it with consultation fees, ICU, it is much less. But there are a lot of bureaus and a lot of help available now, but none of them are cheap. I appreciate the fact that probably they are something that upper middle class and upper class are the ones who can afford it. So the lower middle class, what happens is that one family member kind of quits his or her job and then becomes the main caregiver for the physical looking after of the patient. So that is unfortunate, because then they lose that amount of salary and income to that household. So all the more reason that, we need palliative care early on, so that even these people can continue their vocation. We can see how we can help and support them. Also, the concept of respite care in palliative care, which means, suppose today I have to travel out for a holiday or for a break, there are places which we should offer where we can shift my mom. She's otherwise independent. She just needs supervision. So somewhere where we can shift her for 5 days or 10 days, where I know she's safe, And I know she'll be looked after, fed well, kept clean, or supervised well, and she'll be looked after well. And I can still continue my life. So respite care is a huge thing. And if you see in Bandra, there is a respite care center opened by Tata Trusts for cancer patients. So those who are not able to, even go out to do their jobs, there is so your daycares, so that the cancer patient can be kept in the daycare and somebody can go and do their job and come. So there are issues that can be discussed. But the whole point is, A, doctors need to be aware. Two, patients need to be aware that they have the rights to ask these questions. They have to ask for us to be able to answer and support them. And the fact that even if there isn't a palliative care department or a palliative care specialist in every hospital, which there isn't, there are very few palliative care physicians. Like Sujeet said, every doctor needs to be trained in the basics of palliative care and needs to swap the hat as and when necessary and be able to address these issues, because everything is available on the web. All you need to do is just pick up that phone and ask the relevant questions to connect the patient to what he or she needs.
So I like that, if I may just ask a question, Pradyuman. I like that concept of respite care. But do you think, Rajam, I know our Indian culture is such that if someone's kept at a different location when the family, say, takes a break, the family also gets stressed. What will happen to the patient when we are away? Then do you think there should be advanced directives or anything in place, or, or you think that's beyond the scope of today's discussion? Because I just felt that many people would be worried leaving someone at the hands of in a new center, in case they're brittle or frail.
So, you've come to a very, very important point. And like Pradyuman said in the beginning, the planning of the road ahead. I'm sure all the senior citizens who've logged in today have planned a lot at work, at home, the financial planning. So again, it's extremely important that when you have a patient at home who has a chronic illness, which is progressive or which is incurable, it is very important to have these discussions of what is called as a living will. It's not just the financial will, but the living will. Yes, the details of that is probably for another day, but we have the rights. Even if we don't have the logistics to write the will and get it certified by a judge, etc., today, it will come. The Supreme Court has passed a judgment that you can express your interest. So if you start talking about it, if you ask the wishes of the patient, document it, and make it very clear to your family doctor that this patient is not interested. For example, I just want to quote a very simple example. I recently spoke to a brother and sister who live abroad, who haven't met their father for the whole entire year of 2020, and who lost their mother in October 2019. So from the beginning of 2020, this elderly gentleman has lived his life alone. None of his children have come, and also recently bereaved. He was 80. Unfortunately, on 31st December, he had a fall trying to change a bulb or something. He hit his head on the corner of the bed. He got up, I think, put some massage. This is what the daughter tells me, that he called me after the fall saying, I vomited, I'm having a headache, I'm taking a paracetamol and going to sleep. Obviously, the daughter from a distance thought, okay, father is probably doing the right thing. And next morning, the milkman couldn't get a response. So he, rang the neighbor's bell, and this gentleman was found unconscious. They just rushed him to the hospital. The next thing, the patient is on the ventilator. 10 days later, this brother-sister duo called me saying, we don't want him to suffer. What can we do? So this whole thing could have been prevented by just having a communication with the patient as to what, because to be honest with you, in an elderly, the probability of an accident or probability of an emergency is much higher. So even if it doesn't happen, great. But in the event that has happened and both UK and US child is not able to come, just if there was a documentation, if the daughter or the son had told the GP or the neighbor that in such an event, please call us or tell the doctor, we want to keep him comfortable. Though I'm not sure how much of this the emergency care would have agreed to. But if there was a documentation or if there was a discussion of something like this whole thing could have been prevented. And they were struggling because the doctors in the ICU were not happy to withdraw care. They said, once we have, though the chances are low, we will not withdraw care. So even doctors, Sujit, are not informed of the law, because withholding and withdrawing care is medico-legally safe and ethically right. If you have documented that it is not in the best interest of the patient, that it is going to cause more harm, more importantly, not the decision of the patient, then actually the doctors can be put into trouble for putting the patient on ventilator when you have said that you don't want it. So I think a lot is desired of the medical fraternity today. Medical fraternity really needs to look at the compassionate way of looking at patients, because tomorrow we are going to be patients.
Sure.
We have a question, in fact, on you spoke about ventilators and pulling the plug. This is a question from an anonymous attendee who says, a few years back, my family had to take the hard decision of pulling out the ventilator for my father. I haven't yet forgiven myself for agreeing to do it. While there is a medical and practical side to it, there's a huge guilt conscious. Please help me overcome it.
So my heart goes out to him, because I know when I decided not to do anything for my father, it was excruciating. And people said you could do it because you're a doctor. I said I did everything that a daughter would do, because if I did everything as a doctor, he would have been in hospital. So, I mean, this is where I think the communication from the doctor makes a lot of difference. If the doctor had sat with the family and said that, you know, it is not in the best interest of your father, he is not improving, we are only prolonging his poor quality life, and prolonging of any life which is unmeaningful is also equal to torture. Though we are not playing God, I mean, we are not hastening or postponing the inevitable. But the point is the way the doctor communicates, how much empathy he gives to the patient, saying it, because it can be very difficult, because the people who live with this decision for the rest of this life, like this person who has asked. And it can be excruciating, because they can keep thinking, have I done the right thing? Have I done the right thing? So I think a doctor's role is very, very important, to explain that what he did was right. And probably this is what the father would have wanted. And probably if he had had a chance to ask, for example, like I say, very often in such a situation, I always ask the son or the daughter, would you ever think of yourself going through such difficulties with tubes in every orifice, being treated like a punch bag with like a pin cushion? And the answer is obvious no. Today, all those people who are healthy, I'm sure nobody stands in front of the altar or faith or whatever you all pray for. Nobody says and prays and wishes that please take me to the ICU, please keep me on a ventilator, or please keep me alive at all costs. Most patients, or all of us, if we think about ourselves, we want the most painless end that can happen. But unfortunately, Pradyuman, only 10% of people die a sudden death, like Abdul Kalam. The rest of the 90 will go through various phases of bed-bound stages. And that is why all the more reason that we need palliative care integrated with curative care, and not palliative care towards end of life only. We need to form a rapport with the patient and family so we can discuss these sticky issues, like Sujeet calls it, difficult dialogues. But it's better done than not done at all.
So we have a question from an anonymous attendee again. What if the hospital one is being treated at doesn't have a palliative or an elder care department? Can one call in a palliative care specialist like yourself, or is there an organization one can approach?
Yes.
So Sujeet very often does call me to Bombay Hospital. So again, I think the awareness, if people are aware of it and they start asking for it, then hospital administrators and other hospitals will realize that yes, they need a department. For example, I once attended a talk by a lady in the US saying that how you cannot think of a hospital without a casualty department, without an emergency department. We hope that in the next 10 to 15 years, we can't imagine a hospital without a palliative care department, because it is something that people go through. People go through suffering during any illness, acute, chronic, and chronic incurable. So that suffering needs to be addressed. And that's why we should envisage a future where every hospital, or at least every suburb in this country, or every ex-population has access to palliative care. Now, regarding we have an informal organization called the Mumbai Palliative Care Network, which is made out of all the palliative care people in the city of Mumbai. So there we do have a Facebook presence, which is called as Mumbai Palliative Care Network. And depending on the area you live in, you can approach those numbers to get help. And one of us will contribute and give you advice or give you suggestions as depending on your needs. And so I think the biggest thing is awareness. People are not aware that such a thing exists, and it's not rocket science. It's, I think, most basic. You don't need fancy equipment. You just need somebody who's compassionate and willing to hear.
Pradyuman, you'd be amazed. Sorry to interject again, that if more patients asked how they can improve the quality of their life at whatever age, even if it's less than 65, 45, 50, we would probably have more palliative care consultants at hospitals. The reason that doesn't happen is because nobody's seen it, as Rajam has said. Nobody's experienced it, those dialogues, those communication. When they see it in the Bhatia ICU, for instance, the resident doctors, the nurses get sensitized automatically. And suddenly they are telling another consultant that, look, this patient is suffering too much. Why don't we get palliative care, or why don't we get supportive care for the patient? Do whatever you need to do all the disease modifying therapies you do, but in tandem, keep the supportive care going. It makes a huge difference. I think it can spread like wildfire if just people are sensitized more often.
Sujeet, I must ask you this question, and I know it's a public forum, but since you mentioned about Bhatia Hospital,
yes,
for a hospital administration, is this because at the end of the day, we do know that they have the trustees and the owners have invested a fair bit on the hospital. So,
yes.
A palliative care is actually going to take away the patient from the hospital, and hence, monies and the ROI, etc. Sure. How did you manage to convince, the hospital that it makes perhaps good sense? I don't know what the business sense.
I had a good CEO at that time. A great CEO who was receptive to it. He asked me just one question: will it improve the goodwill of the hospital? And I said, 110%, it will improve the goodwill. He said, then we will do it. 6 months after Rajam joined, she was pulled away by Hinduja to look ahead palliative care at Hinduja Hospital. And I had to drag her back a bit and say, you can go there, but you got to remain at Bhatia. But it is tough. Pradyuman, your question was a very pointed question. It is tough. And I think the only way patients want to visit their doctor feeling happy leaving the clinic, satisfied with the consult. Patients want to leave a hospital feeling satisfied. Satisfied and the patient not satisfied. So today's hospital majority, a lot of hospitals' priorities are bed occupancy, number of imaging studies done, number of blood work ordered. Look, just compare it to the UK. Okay, I'm not saying it's ideal, but the UK has a public healthcare system, and they have probably one of the largest network of palliative care consultants in the UK. They want to empty their hospitals. They cannot handle the loads. And this is even before the pandemic. In India, we want to fill our hospitals half the time. This is the objective of the hospital. So you can't have such priorities. You're not going to get satisfied patients leaving clinics or hospitals that way. So somewhere that has to change. And I'm not saying there are not things that medicine has advanced, technology has advanced. I mean, we have great drugs for asthma. We have antifibrotic drugs for lung fibrosis. We have stents for coronary artery disease. Do all that, but also talk a little about the quality of the patient's life moving forward. That's all. And it will make such a difference, Pradyuman, to the patient's health, rather than medical care. As someone rightly said, today we seem to be living in a world of medical care rather than health care. And that's the tragedy that we need to get out of.
So we have a question from a person who says...
Before you move on, Pradyuman, can I add one more thing? There's a little bit of a joke in the palliative care world saying corporate hospitals in India where the rich cannot come out and the poor cannot go in. And, it's a very odd thing to say, but actually speaking, if you have good palliative care, your turnover is better. You put in those patients who will recover and go home and sing praises of your hospital. And if you, for example, if you admit a patient to the ICU, the maximum expenses, blood tests, imaging is all in the 1 week. If in 1 week your patient is able to get diagnosed or cured and started on the treatment, you have the bed available for the next patient. While if you have a patient who's chronically ill, he's going to occupy that bed for 4 weeks. So where is the revenue generation point from the economics point also? Plus, he's going to say, yeah, this hospital has put me on this and then they did one thing after the other and they gave me a big fat bill of 15 lakhs. So there's no goodwill. Patient suffers, family suffers, there's nobody addressing that, and your turnover is also the same. So in that sense, the more the turnover, the better. And if you see from the COVID angle also, because of the overwhelming number of people we had who were so sick at the same time, you really needed to have the information and knowledge to triage patients and give those patients the ventilator and aggressive treatment who can be survived or who can be back, saved and sent back to society to earn a productive living. Here we had issues of 80-year-olds and 90-year-olds and families saying, oh God, what should we do? We've had so many Zoom sessions, Sujit and me, with families saying, advise you not to. Literature suggests they don't do well. So do you want to get into something when you know the prognosis is poor, or give comfort care? What I must emphasize is that patient has to be comfortable at all times. If we say, don't do this, we also have to follow it up with do this. Because very often we say, don't do this, don't do this. But what to do? That is what the patient needs to hear, which is also very, very important.
So we have a few specific questions which I'll come to now because we are
running out of time.
Well, this is an open kind of thing, but still it's 55 minutes past 5. We have a question from KPM who says, my wife 68 and myself 77-year-old are living alone and had issues recently with my wife's surgery and radiation. Both children are abroad. Can hospitals assign caregivers even upon payment to senior citizens?
Sorry, I didn't get the last point.
Can a hospital assign a caregiver on payment to a senior citizen?
So I don't think hospitals have the wherewithal to have ayabais and ward boys, but yes, there are lots of bureaus who can help you. And the whole list can be shared on the Seniors Today website if necessary. I can supply you the information, the contact people. But what you really need to do is, get their Aadhaar card and get their photograph. I would also request senior citizens who live alone to share that information with the building secretary and the watchman so that they know that this kind of a person is living. Also, I think what I also advise senior citizens who live on their own is to, inform the local police stations, because I have had the experience where they visit every 15 days to check out the well-being of whether they're being troubled by anybody, etc. So these are important things, because you're letting a strange person come into your house. Keep the neighbors informed, send those pictures to the building office, etc., so that you're sure that everybody is aware that this person comes in. For the children living abroad, what I did was had CCTVs in my house. So I knew exactly on my phone what this ward boy was up to, because there's a lot of elderly abuse also that we are hearing, especially when the caregiver is alone with the caretaker is alone with the family. So you have to sensitize like how you sensitize children about abuse. Very often you have to talk to elders, saying if they talk rudely, if they push you or pinch you or stuff feed you, you really need to complain. Because what happens is often elders say, oh no, I cannot burden my son, I cannot burden my daughter, already he's doing so much for me, or he's spending so much for me. But it's better you say it earlier rather than later. So it's my request that, train adults also to recognize abuse and ill treatment. So that's very, very important.
So what we will do is we will share the takeaways from this session, and the video will be put up on Monday on the Seniors Today website, where we will share this list, as well as we will share the contact of the palliative care associations in Mumbai and other cities. And in case you're not able to reach across to any of them, please reach across to us at Seniors Today, and we'll help in connecting you to the right place so that you can get help as soon as you can, as soon as possible. We have a question from Atman Daftari, who says, please define passive and active euthanasia, which is illegal.
So we are not talking of euthanasia in this country for sure. It's not allowed. Also, passive euthanasia is a misnomer. The Supreme Court, we are now filing a petition to remove that word called passive euthanasia. So active euthanasia is where the intent is to kill. So when you talk of active euthanasia, it is basically physician-assisted suicide, where you have a lethal medicine. The patient comes to your clinic and you inject, and the patient dies at the end of the injection. or it is something that the patient gives you a preloaded syringe, you go home and inject yourself. So that is, the intent is to kill. While in a country like India, we do not talk of euthanasia. One, because it's illegal. Two, our whole purpose is to comfort the patient. For example, why does a patient want to end his life? Because he's suffering. So if you address his suffering, which may be physical, emotional, psychological, financial, maybe he will not want to end his life. So in a country where there isn't any robust palliative care, talking about euthanasia is pointless. Our aim should be to see to it that our countrymen have access to palliative care, have address to their suffering, and at least acknowledge the fact that yes, we can try to do something about it, because then that person might not want to end his life. So euthanasia is something that at least for myself, I don't think it should be an option. And passive euthanasia is a misnomer. The Palliative Care Society of India, which is the Indian Association of Palliative Care, has submitted a written this thing to the Supreme Court to remove that word of passive euthanasia. We are only talking of robust palliative care and active euthanasia, which doesn't exist in this country.
Thank you very much. We have a lot of questions that have come in. Some have been answered already. Some have perhaps not exactly relevant. For instance, Arun Kumar Mathur asks, how does music help in maintaining good mental health? But I'm not very sure whether this is the purview of this discussion.
But Pradyuman, music can be a great part as a part of palliative care. It's one of those non-pharmacological treatments. Music, acupressure, acupuncture, pet therapy, any of those massages, all this helps a lot to distract a patient's pain, breathlessness, agitation, just the familiarity of his room, the calendar, the watch being in the same position. It all is very soothing because that's what he or she is used to. So music therapy, yes, very, very good. In fact, most of my ICU patients, I think Sujeet will recollect, especially when they're actively dying, I tell them to get an iPad or a iPod so that they can listen to what they're familiar with. At least the noises is not of the horrible beep and crashing trolleys and all of that. At least that pleasant feeling during transition. I think it makes a huge difference to at least emotionally and subconsciously calm the patient.
I must tell you that over the last 3 to 4 months, we've been conducting at Seniors Today a music contest for senior citizens, and it is so amazingly popular. The number of people who have participated in it, and we have come to the end of the second season, and which is going to be happening on the 17th, and we are all set for the third season, and we have several applications which have already come in. So one, that there is a fair amount of enthusiasm, and second is that they are so well engaged, and they really participate well, and they are combative in their aggression in terms of the rules and regulations, etc. So it's very good. This is all about palliative care, etc. But we have a question which has come in, which is relevant for both of you. This is about somebody having some a lung disease. So I know it's not about this, but it's only important that we respond to it. I've been diagnosed with interstitial lung disease, which has with 2 prominent scars on lung walls, classified as IPF, which has progressed from March 2020 to 25% increase in December 2020, as shown in the CT scan done on 19 December at Sakara World Hospital in Bengaluru. I am on Symbicort inhalation twice a day, with Pulmoclear twice a day, Perfenidone 400 mg thrice a day, Nintena 150 mg twice a day. Am I on right course? Do I need to take any additional treatment? I'm sorry, this is not exactly part of the discussion, but medical advice, and I think it's only important that we give it.
So if the patient has IPF, Pradyuman, then we do have a very small number of patients who are on 2 antifibrotic drugs, which this patient is on. I think 2 antifibrotic drugs is not what is recommended actually all over the world, but if you're on 2 drugs, that's okay. Monitor your lung function. These drugs slow the progression of your IPF, and that is the only treatment available today for idiopathic pulmonary fibrosis. Having said that, this is what the regular chest physician will tell you. And as we have evolved, we have realized that There's also a lot of other things you can do, like physiotherapy, rehab. You can use oxygen judiciously if your oxygen is low. If your oxygen is not low, you don't need to use it. If your oxygen drops on exercise or activity, you may need to use it that time. And so we normally tell our patients whose oxygen drops below 85 on exertion to use oxygen 5 minutes before the activity, throughout the activity, and for 5 to 10 minutes after the activity is over. So those activities could be just their regular daily physio, walking inside the house, walking outside the house if they can afford a portable oxygen concentrator, and also passing a stool. These are all strenuous activities for any elderly patient, and the oxygen tends to drop a lot. So talking to friends at home. But if they're above 88% on the pulse oximeter when they're sitting at rest, they don't need to take regular oxygen, most of these patients. So you need to understand how to take your oxygen well, continue the antifibrotic, meet your respiratory physician at least once in 3 months, do your lung function once in 3 to 4 months, and maybe a CT scan if your lung function is dropping. So that's a lot about what I talk to the patient with IPF. When Rajam takes over, there's a different Pandora's box that is open. Maybe Rajam would like to answer that.
So this is the profile of patients that Sujeet does refer to me. So I think I first start with asking the patient what he has understood about the illness and the fact that there are very, explain the disease prognosis, the disease trajectory, understand who has come with him and understand what they understand about the illness. But because very often the parent is trying to please the child, saying, the child is constantly saying, we should go to this doctor, try second opinion, try third opinion. This is also available. Google search. I have seen that this research is done in this country. Can I do that to my father? So we need to have them all on the same page. And then I explore and explain to them saying, if you understood that your illness will progress in this manner, how would you want to be treated? And that's when the discussion happens. So it unfolds with over 5-6 sessions. And what is heartening is, despite the pandemic, we've still managed to do it across digital platforms. And I think both Sujeet and me agree that we've had a lot of input, because now we speak to the son from California and the daughter from Melbourne also, all at the same time. This didn't happen in the past because we used to deal with people who could see face to face. But now, because it's a digital platform, we managed to do this. And because very often what happens is people who are not in the country, they tend to not realize the ground situation and say, why are you talking this? Keep doing this. I will send you the money. Keep trying things. So we really need to involve all the stakeholders so that the decision is made in the best interest of the patient. So this is what I do, is talk to families, slowly try to make them understand and support them in whatever decision. So there's no I told you so, and there's no right or wrong. It is what it is. It is what fits that particular family. So that is important. And we aggressively address quality of life. We aggressively address symptom control. So if the patient is breathless, we give them medications to decrease breathlessness, because I can't change the anatomy of the lung. If the patient wants to do a particular thing, we do physiotherapy. So he develops the stamina to be independent in the toilet or go and sit and have a meal with his friends in the club or whatever. We encourage portable oxygen for people who can afford it, so that they can step out of the house and are not homebound and housebound. So there are small things which might be something that we all take for granted, but for the patient, it makes a huge difference, because it's a complete change for him, his life and his quality of life, to do what he enjoys.
Now, to add to that, Pradyuman, the thing is that how do you improve the quality of life with medication which is not targeted to the disease but to the symptoms? And one example is just usage of morphine. I mean, our usage of morphine in India is a small fraction of what the use in the UK is. It's a tiny fraction. The highest use of morphine is in Kerala state. I mean, Kerala state's use of morphine is more than all the states put together in India. So just using a simple drug that is pretty safe in these patients can make such a huge difference. But it's not done. It's not very often done. People perceive morphine as something to be given at the end of life or something, which is again, it brings you back to the thing, palliative care is not about end of life care. It is about living a good quality of life. And we face this situation, I face it very often with my colleagues, who think that if I involve palliative care, that means, oh, this patient is going and, you're giving up on the patient. Not at all, far from it.
No, thank you very much, uh, Dr. Rajam Iyer and Dr. Sujeet Rajan, for this wonderful session. I think we've discussed a fair number of issues which I think needed to be discussed, because from the discussion itself, I'm sure a host of our uh, readers here and all those who have gathered here will benefit considerably, and on the need to look at palliative care, on the need to approach uh, this whole uh, this whole method of spending your time when you have people with chronic illnesses, on how you deal with them, and what is the right approach. So thank you very much once again for all your time, and I think we haven't ended the discussion really. There's so many other issues that are there, so I'm going to perhaps have you come over once again after a couple of months to ensure that we discuss this and more issues around elder patient care. Thank you once again, all of you. We will
Thank you so much. Pleasure is all mine.
and absolutely, and Dr. Rajan, thank you for suggesting
Thank you.
the idea that we must do this. And
Thank you. If I can add one thing, Pradyuman,
yes.
thank you so much for getting this topic on board. I think it's also important that people have Rajam's email ID, because Rajam has such a huge network across India. I need a palliative care physician today with technology. We are entering the ICU in Guwahati and Bhubaneswar, because someone wants a second opinion. We need a palliative care doctor there as well on board during that consult. And Rajam gives me names all across the country. So I think it's very important that people are aware in their area where such support is available. And if we need to do more sessions on this with specific topics, I'm sure Rajam will give you people who are very experienced in this space.
Absolutely.
What we will do is on Monday, when the takeaways are carried, we will have your coordinates in there so that people can approach you directly whenever they need any help. Thank you once again for your time and for this session, and I must salute you for the kind of work that you all are doing in terms of elder care and making their the years that they are here a lot more happy and healthy. Thank you once again, and we will be back again next Saturday with the Health Live session. We are going to look at focusing on the vaccine, which would have arrived hopefully by that time. So that's our focus next week. So please come by again next Saturday for Health Live. And thank you once again, Dr. Rajam Iyer and Dr. Sujeet Rajan, for this.
Thank you very much. Thank you for this opportunity.
Thank you.
Bye-bye.